So we're all very excited about this meeting today. We've been looking forward to it for a very long time. For those of you who don't know me, my name's Karen Edison, and I direct the Center for Health Policy here at the university. The Missouri Health Equity Collaborative is the organization putting this meeting on today. It's led in our Center for Health Policy. Nancy Mackinaw is sitting right over there. Raise your hand, Nancy, and she's the project director for this program. Iwana Staslescu and many others in our center are critical to this program. I really want to thank our funders, particularly the Missouri Foundation for Health, and Dr. Hughes is here today. You want to raise your hand? Yeah, thank you for that. The Missouri Foundation for Health has been very interested in health equity and health disparity for many years through Ryan Barker's leadership and others. Is Ryan here? Hi, Ryan. Okay. The Healthcare Foundation for Greater Kansas City has also been a funder for this activity in the past, and really we have folks from all over the state that are interested in this issue and want to improve health for all Missourians. I'd also like to thank the School of Medicine, the School of Nursing, and the Office for Medical Education that helped us put on this meeting. Lindsay Beckman is here and has done a lot of work for this meeting. Lindsay, where are you? Okay, she's probably out working. Also our sponsors, the Missouri Hospital Association, the Missouri Primary Care Association, the Missouri Institute for Clinical and Translational Science, the MU Master of Public Health Program, the MU School of Social Work, Primaris, Missouri's Quality Improvement Organization, and the U.S. Department of Health and Human Services. So please give a round of applause for all of our sponsors. A little housekeeping, please turn off your cell phones, please turn off your pagers. The bathrooms, I think you know, are down this hall. I was reminded this morning that in 1966, Dr. Martin Luther King Jr. said that of all forms of inequality in our society, injustice in health is the most shocking and the most inhumane. And I think today we come together to shine a bright light on some of these health equity issues. Sometimes people say to me, well, why would you have a big meeting? Why would you have people from all over the state? Why just have a meeting and talk about everything? And I look at our responsibility as healthcare providers. You know, I'm a physician and my responsibility is my patient, but as healthcare providers, our responsibility is our population. And I can't treat my patient if I don't have an authentic understanding of what the issues are. And we can't improve the health of a population if we don't have an authentic understanding of what the issues are in that population. We know that health does not begin at the doctor's office or the hospital. We know that it begins where we live, we learn, we work, and we play. And I was thinking this morning, you know, it's about all of the social determinants of health. It's about clean air and safe streets and healthy food. I apologize for our breakfast. We could have done a little better in the healthy department. But it's about many things you're going to hear about today. You're going to hear about a lot of the problems and a lot of the issues, but you're also going to hear a lot about best practices and promising programs for the future. And even if you're hearing about what the problems are and what the disparities are, I want you to be thinking about what can we do to make this better, because it's going to take all of us, all of our brains, working together to improve healthcare for Missourians. And I think it's an exciting time. Whatever the Supreme Court does in June, this is a critical time for all of us. We can think about this anew. We can have healthcare. We can deliver healthcare. We can be healthy in a different way than we ever have in the past. So I hope you feel excitement for today, and I hope you'll put on your thinking cap and join with all of us in thinking about how we can do things better. So without further ado, I'd like to welcome our first keynote speaker. We have two wonderful keynote speakers today. Dr. Darrell Kirch is going to speak first. He's the president and CEO of the Association of American Medical Colleges. That represents the state's medical teaching schools, the teaching hospitals, the medical schools, and the academic societies. He's a distinguished physician, educator, and medical scientist, and he speaks and publishes widely on the need for transformation in the nation's healthcare system and how academic medicine can lead that challenge. He's been dean and leader of academic health systems at 2 institutions. He's co-chaired the Liaison Committee on Medical Education and now serves as member-large at the National Board of Medical Examiners. And he's a member of the Institute of Medicine of the National Academies, and that's a very big honor. He's a psychiatrist and clinical neuroscientist by training. He's a native of Denver and earned his BA and MD degrees from the University of Colorado, and we won't hold that against him. So please join me in welcoming Dr. Kirch.
Yes, I went to the University of Colorado, and I personally want to apologize for that 5th quarter thing, for those of you who can remember. And I do have a tie here. I have early childhood memories of summers on my uncle's farm in Butler, Missouri. Unfortunately, I have terrible allergies, and that was not always the easiest experience, but it did tell me how friendly people in this state are and how down to earth you are, which means I'm going to remove my coat, okay? And you're going to, if you're in one of those chairs that has you awkwardly positioned, so you have to twist around, scoot your chair around, get comfortable, put your iPad in a spot where you can discreetly type. We're not going to stand on ceremony here, but I had some colleagues hard to put some information together on the slides, and you want to be able to see them. See, you're going to have to turn your neck, twist your neck, so you want to swing your chair. I love embarrassing people in the audience. Okay. So I'm here to help put a large context around the discussions you're going to have today, to sort of frame this in terms of where we are as Americans and what we face around healthcare. I'm not an expert in health disparities. You're going to hear from one at noon from Johns Hopkins, who I think is going to give you some wonderful information. But I have had a chance to see the way healthcare works in our country, to also see how it doesn't work, to see it at its best, and to see how many people it leaves out. And I'm going to try and give you a way to think about this all that hopefully will answer this question. This is actually the wrong question. We can do anything we want. We're the richest nation ever seen on this planet. We have 300 million plus of the most creative people ever brought together in the world. We can do it. The question is really, will we do it and when will we get to it? And I feel a sense of urgency about it, that we have to do it now. And I'm going to describe to you why I feel that way, how I think we got where we are, why I feel the sense of urgency today, and what I propose we do about it at the local level, the regional level, and the state level. So, how did we get where we are in healthcare? Well, this is an interesting place in which what happened in medical schools and teaching hospitals directly influenced how the whole nation went over the last century. So we're going to cover that century very briefly in a few minutes and a few slides by focusing on 3 men and what they did over the last century that shaped us to where we are today. The first one was that dour-looking character in the middle. His name is Abraham Flexner. And some of you may know, 100 years ago, he cleaned up American medicine. 100 years ago, you were as likely to run into a snake oil salesman in Missouri as a real doctor. America was rife with chaos in healthcare. We had storefront medical school. This was a real medical school in New York City called the Eclectic Medical College, believe it or not. You can actually see is there a laser pointer on here? Never mind. That's the Eclectic Medical College. You basically just bought a degree. You didn't have to really study anything. He looked at Johns Hopkins. Some of you may have been in Baltimore and seen it. He said, that's the model. And the key to Johns Hopkins was that you should bring the medical school back to the university, back to science, back to having the faculty actually teach in a hospital. And that's what places like the University of Missouri here and St. Louis, where I was yesterday, WashU, where I was the day before, UMKC and all the other schools I visited. That's the model we all followed. In the upper left-hand corner, we're building new medical schools even as we speak, and that's Hofstra University School of Medicine, newest school of medicine in the U.S., just opened its doors. We all followed that model, and we did come back to the university, including coming back to an emphasis on the culture of the university, a very expert-centered culture, very individualistic. The second man who shaped us after World War II, as much as anyone, was Jim Weingarten. He was really one of the fathers of the NIH. I had the privilege of working in Bethesda at the NIH for well over a decade. It's an incredible research institution, and it really has given us the best science in medicine in the world. But it also brought us to a culture that was very focused on expert investigators. It actually, the way NIH funds research is it gives grants to individuals. So the focus is very much still on the individual, autonomous, scientific, medical expert. And then another legacy that shaped both medical schools and healthcare in general came from this man, LBJ. I recently learned that Harry Truman, favorite son of this state, was present, and I think that's Bess Truman behind him. He was present when Medicare was signed, and during the ceremony, I hadn't known this, but somebody had seen this in Independence. During the ceremony, LBJ signed up Harry Truman for Social Security. Seriously. And he witnessed the form that deducted $3 a month from Social Security checks to help pay from wages to help pay for Social Security. Now, how did Social Security, or Medicare, I'm sorry, I'm mixing up Social Security and Medicare. How did Medicare and this legacy change medicine? Well, it ensured that people who are older would get health care, but it also ensured that we would pay for health care in a fee-for-service way. So Medicare doesn't pay your health system a lump sum to take care of people and keep them healthy. It pays doctors piece by piece for the work they do. Fee-for-service gives people an incentive to intervene, to do a surgery, to order an x-ray, right? It doesn't give people incentives to stay healthy. It gives them incentives to use sick care. And because it's paying individual doctors, it reinforces that culture of individualism. So that 100-year history gave us a culture focused on experts, building good science, creating good drugs, but it's all about individuals rescuing people when they get sick and being paid for doing that. That was the way medical schools built up, and that's the way the whole healthcare system built up. And in fact, in a great irony, medical schools are the only part of the university that is involved in business in a big way. You know, do university law schools run big law firms? No. Do engineering schools run power plants or factories, or business schools run banks? No. But medical schools deliver a huge portion of the health care in the United States, and university teaching hospitals do, the members of my organization. So we built up great biomedicine. When I was a med student, if a child developed leukemia, they had an 80% likelihood of dying. Today, they have a better than 80% likelihood of surviving that leukemia. That is wonderful. That was excellence. You know, it yielded great things. And please don't leave here thinking I'm saying that medicine over the last century was a failure. Those are fantastic advances. But do you feel that we achieved excellence in our healthcare system over that last year? Actually, I think at least somebody was there yesterday. I was giving a talk at St. Louis University, and a gentleman raised his hand and he said, you know what, people come from all over the world to get health care in the United States. We have, without doubt, the best system of care in the United States. He was a surgeon, and he said, you know, I have patients who come from Europe to be operated on here. And I said, well, they may come for your surgery, but I have yet to meet anybody who left another country to come to the United States for its health care insurance. Great interventions, flawed system, not an excellent system. And we see it illustrated. You know, you can look at the nightly news and you can see the latest robotic, minimally invasive, high-tech image-enhanced surgery. And then we can flip on the news a few days after Katrina and see patients sleeping on the floors of the airport in New Orleans awaiting rescue because we couldn't even take care of the people in our own healthcare system. And Katrina is an extreme example, but every day in your day-to-day work you see people who aren't benefiting from a great healthcare system. It's a system rife with inequities. Unfortunately, one of the inequities is it costs more than any place else in the world. So we're now at this point where we're spending probably $2.8 trillion, that's a T, $2.8 trillion a year on health care in the United States. That's an inequity. No other country comes close to spending that much per person or that much of its gross domestic product on health care. This compares us to other developed nations. You know, even Switzerland, that wealthy nation, spends much less than we do. And in a great irony, knowing what we know, knowing that one way to keep a community, to keep a person, a community, a nation healthy is to support them socially, to give them a good education, give them a good transportation system, give them good housing, even though we know that would help that healthcare spending yield benefits, we underspend compared to other developed nations on social spending. So we worsen our problem of spending so much, and we get less value by underinvesting in these things, things that some of your posters allude to as being part of creating healthy communities we don't invest as much in as a nation. And then the equities become much more glaring and visible when we dive deeper into health care. The current number of uninsured is probably higher than this, probably more than 50 million Americans, a number of people equal to the entire population of all those states. It's as if we decided to say we're going to leave this part of our country out in the uninsured cold. And then those uninsured aren't equally distributed through our population. We have inequities. In, I'm sorry, I think I lost a slide there. I did. Everyone knows that the uninsured percentages are higher in Hispanics, American Indians, blacks. So there's inequality across that. And then even if you have insurance, there is inequality. For the women in the audience, I'm sad to tell you, you have a pre-existing condition by virtue of being female. And so if you're insured and a woman in this country, the blue states on the left are the only states in which women pay roughly the same for health insurance as men, in which there's a requirement that occur. Now, the Affordable Care Act would even that out. But for now, if you're a woman in Missouri on average, and compared to a man trying to purchase the same health insurance, you'll pay 26 to 50% more for your health insurance. Now, will the Affordable Care Act, when it's passed, when it's implemented, make all this go away? It'll help. Can you read these in the far back? It's probably a little, you can? Okay. All the more reason, if you can't, to upgrade yourself to one of these first-class seats that are left in the front. Even if the Affordable Care Act expands its coverage, as described here with Medicaid and insurance exchanges, what about these 23 million people who still wouldn't have insurance, even with the Affordable Care Act? The odds are many of you work in settings where they'll still be at your doorstep. And as you said, excuse me, I get excited and start throwing coffee around. As you said, these 9 people are now going to tell us whether the Affordable Care Act even goes into effect. Now, I follow this very closely. I work in Washington, D.C., and I can tell you with virtual certainty, when the decision comes down, it will be divided 5-4. I just can't tell you which way. I don't know. Nobody knows for sure. Will it be upheld in whole, in part, totally overturned? We don't know. So we talked about the inequity in terms of what we spend. We talked about the inequity around insurance coverage. And then there's this problem of just the basic ability of our fellow citizens to understand health care, something we call health literacy, demonstrates great inequities. Unfortunately, illiteracy when it comes to health is present in all groups. This is a scale that's used to measure health literacy. And even the best group, white Americans, only score 256 out of a possible 500. And you can see how among other groups the level of health literacy falls off. My daughter teaches in an urban Spanish-English immersion program. She teaches kindergarten. And I was actually talking with her about this. And even at age 5, she sees differences in the different groups of her schools and how much they understand just about very fundamental health issues that you would think a family would be teaching their children at that age. So, all those inequities then wrap up into inequities in how it all comes out, our outcomes. I don't show you the global data because it's shameful. Last year I've been to Germany, Singapore. Before that was in the UK. The worst part of those trips for me is when I'm sitting at dinner with physician colleagues from other countries and they say, "How can you stand it?" You know, as a highly trained physician, how can you stand living in a country that has the worst obesity rate in the developed world, that has one of the highest infant mortality rates? And then for you as citizens of Missouri, on many indices, you actually do worse than the terrible U.S. rates compared to global standards. Obesity is such a epidemic problem. I encourage you to look out for, I have to always say this, I'm not encouraging you to subscribe to HBO, but if you do, I encourage you to look out for a series that HBO will be airing that was developed with the Institute of Medicine called The Weight of the Nation. But one of the points they make is just 20 years ago, only 15%, there were no states in the U.S. in which more than 15% of the people were obese. Today, in every state in the U.S., more than 15% of the population is obese. So you see all of these kinds of deficits wrapping together in terms of access to health care and our outcomes. And it's shameful. And as we try to rectify them, we have another inequity in that we're looking at provider shortages. My organization tracks very closely physician shortages. We were actually having a breakfast conversation about how it gets harder to know just what Missouri's situation is, but I can tell you I doubt that it's better than the national situation. And we're looking in just 8 years at being short 64,000 doctors in the U.S., even if the ACA isn't implemented. If it's implemented and gives people more access to health care, we may be short nearly 100,000 doctors. And some of you are living and working in parts of this state now where the shortage is there today. And you experience it day to day when you try to make certain referrals. Now, I'm a board-certified psychiatrist, and I took an oath to not depress people. But I'm not saying I'm here to now medicate you. What I'm here to do is hopefully recruit you. Because as a nation, I believe we are increasingly prepared to address these inequities. I see motion on multiple fronts, and I would like to see us accelerate that motion so that we can really get a handle on these issues. I see the motion at the federal level. This was the recent report from ARC. All of these, I'm almost certain, are available to you online if you want to look at them. I especially liked the vision in this HHS report. It just sounds so wonderful. A nation free of disparities in health care and health. And even the popular press is picking up on it. It was, I think, earlier this year that this New York Times editorial came out where somebody said, you know, let's get wise as Americans. If we want to fix health care, one of the most immediate things we could do is help the poor. It would be amazing how good our health status would be comparatively as a nation if we could just close some of the poverty gap and just get the educational levels up among our citizens. So there's some momentum. We see what the inequities are clearly. We understand how they're linked to these social issues. Who's going to take it on? Well, I believe the organizations I work with are uniquely positioned to take it on for the reason I described earlier. Medical schools, their teaching hospitals, aren't sitting off in some ivory tower. They're delivering health care day to day. So I headed the medical school and the health system for Penn State University in Hershey, Pennsylvania, and I would sit in my office not just reading scholarly works. I would see the trauma helicopter flying in and out off the helipad, you know, with the victims of violence and roadside accidents, the underweight newborns coming from around the state to our NICU. So we're not in the ivory tower. We're central to the healthcare system. In some ways, we're the most organized component of the healthcare system. But we've become disconnected from important aspects of the healthcare system. With really some exceptions, we've become disconnected from the community health centers, from the community-based mental health, social services systems, from the school systems. So part of the reason that the format of this meeting appealed to me so much is it's a chance for me, coming from that academic medical health care system, to talk to so many of you coming from these other components to say, it's up to us. If we don't partner on this, nobody else is going to do it. I really doubt that the insurance industry, health insurance industry, has any great motivation to take this on. I doubt that the pharmaceutical industry sees it as their problem. And I can tell you from personal experience, Congress is not have it in itself to fix it. So it's up to us. So what is our path forward? Diversity, embracing diversity, I would argue, is our key to further understanding and ultimately resolving these disparities. Inequities are the negative side. Embracing diversity is the positive side of this dynamic. And so the AAMC has really committed itself 2 years back when we went through a strategic thinking process to putting advancing healthcare equity on the front burner. And I'm going to give you a sampling of the things we're doing that we think we have a special leverage about, special leverage to work on, rather, in medical schools and teaching hospitals. And then we're going to have a good time for discussion so you can talk about what the community can bring to this table as we work on this. And I'm going to give you examples that really embrace all of our missions. But if you're more interested in what we're doing in this regard, that web link at the top is a good resource for you. We are a broad and deep organization with lots of assets. And there may be things there that you will find are really valuable to you. This is actually a link to a video you can click on, which is one of the most compelling video pieces I've seen. It's only about 3 minutes long. That really makes the case statement about why we have to promote diversity in the service of attacking health inequities in our country. So let's talk about kind of 3 things we could do and how the missions of academic medicine can be part of this problem. I would submit to you that we need to rethink who we bring to medicine, really who we bring to health care, in order to get at this problem deeply. The AAMC is very, very involved in the whole process of bringing people to medicine, accepting people to medical school, which is the gateway to the profession, the doctors in our country. For years, it's no surprise to you, the emphasis on bringing people to medicine has been how smart they were. But it was a pretty narrow definition of smart. It was a definition that got shaped by how you did in calculus, organic chemistry, physics. I know all of you, when you go to a new doctor, the first question you ask them is what their grade was in calculus. But that's been, for better or worse, one of the most heavily determinant factors in medical school admissions. With the support of medical school deans like Dr. Churchill and others, we've been rethinking even that academic readiness component. I don't know if you have heard any of the news stories, but we finally have agreed that we will redesign the MCAT exam, the anxiety-inducing MCAT exam, so that it includes social and behavioral sciences, so that it acknowledges that the social and behavioral determinants of health are every bit as important as what your genes are from your mother and father. And then we're going to expand that. We're going to look at pre-professional readiness. I'm sure none of you have ever encountered a doctor who was clearly very, very smart but not great on the communication side. We've developed a working list of what we call pre-professional attributes, things like integrity, resilience, communication skills. And we're working on tools and how to assess them better in applicants. And we're looking for diversity in all forms, not just racial and ethnic diversity, but experiential diversity. We've been really struck over the last 2 years that one experience that seems increasingly common among successful medical school applicants is that they did Teach for America or City Year, programs like that demonstrate this broader picture of somebody who's ready to bring excellence to this attack on health disparities. You can read this, I won't go through it, but this was the medical school application world we lived in before. But we're trying to create a world where every admissions committee, and I know Mizzou has been working on holistic admissions for some time, is really focusing on these attributes. This is really totally trying to send a new signal. So in the past, when you started down this pathway to being a doctor, most people were just totally focused when they were pre-meds on the test, right? I tell this story everywhere because it just is so amusing to me. So I have a daughter graduating from the University of North Carolina, Chapel Hill, in 2 weeks. And she's very smart. She's a wonderful, wonderful person, but she is also one of the most social people I've ever met. I think she knows everybody in Chapel Hill. Well, you can't believe how popular I've become in Chapel Hill when all the pre-meds at UNC found out I was president. President of the AAMC. The sad part of it is, she says, so-and-so wants to go to medical school, Daddy. You know how when they want something, they call you Daddy? so-and-so is interested in medical school. Would you talk to them? And I do. And I wish they wanted to talk to me about what would it take for me to be successful as a family medicine doc, as a surgeon. They want to talk about the MCAT. So we're trying to send a very strong signal that detoxifies that kind of tyranny of the MCAT and says, we have to correct health inequities in this country, and it's going to take real people with diverse experiences who understand all the dimensions of cultural variance in America to get at it. A second front on this war for us is not just to pick the right people, but to shift the culture of healthcare. Now, culture is a funny word because we don't talk about culture. You don't take a new job and walk into the organization and say, well, let me see, what's the culture here? Instead, you just kind of experience it for a while, and people talk about the way we do things around here. Or you notice how people treat each other or how they behave. You notice how people handle power and authority in the organization. You even notice body language and gestures. And gradually you get a sense of what the culture is, right? Well, remember when I talked about those legacies, the culture of the university, the culture of independent scientific investigators, the culture of fee-for-service, reimbursing experts for their procedures and their tests? Well, that has become the culture of American healthcare. If you look down this list, this describes the medical world that I grew up in. It was extremely hierarchical. You know, I was told to focus totally on exactly how I moved from student to resident to chief resident to assistant and so on up the ranks. You know, I looked forward to those points, that point when my white coat could go from short to long because I was climbing the hierarchy. It was all about me as an independent, autonomous person, and believe me, it was competitive. How long is your CV? Well, mine has actually got, weighs this much. Because I use bigger font to print my CV. And it was about me. It was all centered about me as the expert. Now, if you have the misfortune this afternoon to be in an emergency room, do you want a string of autonomous, independent providers coming in and out of your room, not really well connected to each other, each enamored of their own expertise, each thinking that the world revolves around them? You don't want that. What you want is this. You want the feeling that you're entering a healthcare system with high levels, collaboration, team-based work, one that's service-based and built around you and your family, patient-centered care, as we call it. This is a huge cultural change for American healthcare and medicine. And since most of the doctors, nurses, pharmacists, and others receive their training in an academic medical center, if this is the culture of the academic medical center, this will be the culture of the healthcare system, which is why we're working so hard to change the culture of the places where providers learn. So that's that second element of building excellence in those people, and it means we're going to need to create different kinds of leaders. So when Dr. Churchill and I became deans when we started in academic medicine, these were the characteristics of most leaders in academic medicines, including the deans that we ended up being one day. The leaders that we need today in academic medicine are much more like the qualities on the left. They're much more transformational leaders, not transactional leaders. They're there to mobilize teams, support them, promote collaboration. It's all about competence and breakthrough performance, not incremental performance. And in the end, it shouldn't be about status. It should be about the ethical fulfillment we'd feel if we actually free ourselves from those inequities. So if we choose people more wisely, and if we promote the culture of the organization and the leadership skills in those people, I think we can start to build a self-sustaining system of change that will really change healthcare itself. Now, 3 years ago, when both presidential candidates, 4 years ago, my gosh, 4 years ago when both presidential candidates, both McCain and Obama, said that part of their agenda was healthcare reform, they both intended to do it. We sat down at the AAMC and thought about what would true healthcare reform look like. And we drew this diagram, and it remains as true today, I would argue, as it was then. We said the economics of healthcare have to change. We have to insure everybody, because having 50 million people who are uninsured distorts the whole system and creates great suffering for them. But not only that, we need to deal with that problem of fee-for-service, where you're getting paid for doing more, for intervening, for rescuing people, and not getting paid for keeping them well. You know, a hospital CEO wakes up in the morning and it's good news if the beds are full. Not for the patients, but for the bottom line. So we knew those things had to change. We knew that we had workforce problems even then, shortages, but it wasn't just the shortages, it's that doctors weren't working well with nurses. Teams weren't forming with pharmacists and social workers. Instead, everybody was down in Jefferson City fighting over who should do what with each other rather than forming up in teams. We knew we had workforce problems, and we knew we had care model problems. Medicare data shows that there was a study in Florida that showed that the average Medicare recipient, older person in Florida, had, I think the number was either 6 or 8 specialists that they saw in the average year, and on average, they didn't have a primary care doctor. That's not a great care model. What that leads to is a person being on 20 meds from 6 doctors with nobody checking how it all fits together. The care model had to change. And then we said, you know what? We've got to change as people. You know, I often quote Tom Gorey, who said the American people are very simple and easy when it comes to health care. They only want a few things. They want absolutely the latest drug or technology, especially if they saw it on House last night on TV. They want it immediately. They want somebody else to pay the bill, and if anything goes wrong, they want to sue. That attitudinal set distorts the system and perpetuates inequities. And then wrapping around it, we knew that culture problem had to be part of the work. What did the Affordable Care Act do? Was it a health care reform bill? No. It was a health insurance bill focused on one small part of that circle. To really do this, it's going to take an academic medical center that's going to have to do what the ones in the state are thinking about. How do we move from fee-for-service models to population payments that actually have components for promoting the health of people? How do we correct workforce shortages and, even more importantly, get our docs, nurses, pharmacists, and others working as teams? How do we change our care models so that they acknowledge the importance of the social determinants of health, incorporating attention to everything from transportation to social work, vocational support? You know, there's a lot of talk about readmissions to hospitals being a problem. When you really look at it, especially for hospitals that care for poorer patients, the readmissions aren't because of bad medical care. They're because people don't have a car to get to the clinic, or they don't have the income to buy their prescription. So our feeling is that if we were to partner more assertively with community partners on all these fronts, we could actually begin to model healthcare reform, because Congress is not going to come back and say, okay, we're going to do the rest of the job now. The worst case scenario is we're going to go back to zero and start talking again about how we get more people insured. It's up to us, academic medical centers, community partners, to get it done. And the other thing the academic medical centers need to bring to the table is their science. If we build these models, we're obligated to actually study whether they work or not. And I'll give you a good example that I learned of in my role working with the VA at a meeting now 2 weeks ago that speaks to the people, the sickest people in our country, the people who have multiple chronic conditions, as some of the more unfortunate veterans do, who tend to consume a lot of health care costs. And they took a group of veterans with multiple chronic illnesses, and it was costing the VA $45,000 a year per patient to give them their health care. They were sick people, in and out of the hospital, in and out of the ER. And they said, we're going to build a new model. They called it home-based primary care. The model actually used more social workers, rehab therapists than it did docs and nurses, but it built teams that went into the home and took care of the patients. And the bookkeepers came back and said, well, that increases our cost per patient $9,000 a year. You know, what's the point in doing that? Well, they went ahead and did the model, but had a research team study it. And yes, it increased. They had to add $9,000 to support the primary care teams, but the health care, medical care cost on each person went down $18,000. Net savings. You know, if we did that as a nation, who knows? We might go from 2.6 trillion to 2 trillion overnight. So we need the science to study what works. I don't want to go into this part because I want to get to the discussion, but I just want to close by affirming in that phrase what you illustrate in real life here. You know, it's more than about medical intervention, surgeries, tests, images. It's about a care system that embraces broad elements of community, social services, and other supports. And that's what you're all about. That's what the meeting is about. I would just like to, again, in the spirit of a campaign, recruit you into saying, let's look for partnerships. Let's look for ways that we can model what the nation needs so desperately right now. Thank you. And I think we have some time for discussion. Questions? Actually, I really prefer answers to questions. But seriously, most of all, what I prefer is your response. I'm usually talking within academic medical centers or within physician groups. This is a much broader group. You know, I may be in some kind of bubble and not have it right. I'd love to hear how this message sounds to you, where you'd challenge it, where you think it might be spot on, where you think the opportunities are. I know people are very polite in Missouri. Yes. Could you stand up and project? Oh, we've got a mic. Great.
I've never been called quiet in my life.
Yeah.
Morning. I'm Tracy Branch. I'm with the U.S. Department of Health and Human Services, Office of Minority Health. Well, being that you were looking for an answer, my potential answer to this problem is ensuring that health providers who are in various disciplines, in addition to having their health professional training, also incorporate public health courses into their coursework. So that, and I think you spoke about it very eloquently in terms of moving from that individual thought to more of that larger social construct. And I think public health would do that. Having that background in public health would do that.
I think that's a great point. And one of the opportunities we're looking at is, as we're rethinking pre-medical studies, what a person who thinks they might want to go into medicine or nursing does, we're working on trying to decrease the load on the biological and physical sciences. Some campuses are working on, couldn't they develop a 1 or 2 semester biochemistry for healthcare course that would replace 4 semesters of general and organic chemistry? And then That would free up time. And what we've been considering is developing a model undergraduate pre-med, pre-nursing course or set of courses on things like the social determinants of health or the structure and financing of healthcare. Things that would start to set a context, a social context, the public health context, population health context. Global health probably should be a target because the world is getting flat. I don't know if any of you saw the news story about the airplane that was held at Midway because they feared there was a monkeypox case from Africa on the plane. You know, that's the way the world is today. And so those would be issues we could build in. It's a great point. Mike's right behind you. Stand up, project, and tell us who you are.
Hi there, my name's John Cummins. I'm a med student, so I don't know why I'm at the front table. What really resonated with me was when you were speaking about student choice, or choosing students, the admissions process, and how that needs to be revamped. And I know that we have a phenomenal pipeline program for our rural track. Phenomenal. It's incredibly successful. It's a model. What I'd like to hear is what other pipeline programs have you seen that are successful or at least intriguing that might be appropriate models for Missouri?
Well, in medical schools, the two most dominant pipeline programs, interestingly, are rural health and physician scientist. And those are obviously dramatically different and miss, I think, a lot of the range in between. My observation is, and you can speak to this better because you talk to your fellow students, my observation is prospective medical students in some cases are designing their own track. So as we've tried to dive deeper into all these students who seem to be coming from Teach for America and City Year, often they're saying, I knew I wanted to go to medical school, but I wanted to engage in a form of service that was deeply embedded in the community for a year or two as real-world preparation for medical school. And I find that very intriguing. And I think schools could pick up on that and, as befits their local situation, maybe build some of those out.
Yeah, and what I have found as an attending in an academic medical school for a long time is, is these kids, I shouldn't call them kids, the young people come in very oriented toward their professional mission and they come to our center actually as first year and second year students. Every year they come and they want to participate in our projects and what we're doing in health disparities and health literacy and all these issues. And then they get into their third year and their fourth year, and it's that hidden culture. It's the culture of the academic medical center. They come out on the end and they're different people. And it's not that they have any less, they're the same person, but their whole orientation and their values and their plans for their future are different. And so I think the focus on young people coming in and how they're prepared is important, but we have to keep in mind there's all of us mentoring them and teaching them and modeling how we deliver care. And I think it's going to take too long to change what we need to change, just focusing on the people coming in. I think we're going to have to focus on us.
And this really is the cultural element. There's something in education called the informal curriculum. So the formal curriculum is, the courses you sign up for. The informal curriculum is what you see people doing. And so you could be the most service-oriented, generous individual on the planet, but if you spend a lot of time hanging around healthcare providers who are cynical, not patient-centered, appear to be indifferent to healthcare costs and so on, that affects you deeply. And there's a lot of attention now in schools to getting the informal curriculum, the culture, where it needs to be. Just a final point related to this is I am struck by how many students come to college and then come to medical school having done unbelievable service experiences. And at a time we're worried about medical school debt, I would like to see us as a nation greatly expand the service opportunities. National Health Service Corps is the most current example, but expand the opportunities into more service opportunities that would address health inequities and pay down debt. And I believe a lot of our students would be eager takers for that. You're going to have to help choose here.
Margie, and then over there. Yeah.
Here comes the mic. Well, they're recording, I believe, so.
Okay, I'm
Look at the camera.
I'm Margie Sable. I'm the director of the School of Social Work here at Mizzou. And I'm aware of a new push in integrating behavioral health and primary care. I know that HRSA is supposed to be coming out with some grants, and I'm here at Missouri, family medicine is looking at doing that and having social workers integrated into primary care clinics, internal medicine and family medicine. And I'm wondering what your take is on that in terms of reducing some of the disparities.
Oh, it's absolutely critical. And the proof was that VA primary, home-based primary care program in which social workers were a key component in developing the program because they played a key role in so many of these subtle but powerful things in the patient's life and family situation. But the point...
Do you see that as a national trend?
Yes. Yes. But it's a national trend only when we break away from fee-for-service reimbursement. Because as long as all of the money is tied to getting sick, getting in a hospital bed, needing a surgery, and not able to flow to a team with a social worker or a clinical pharmacist, it hinders putting that in place. So the systems or the groups of patients who are being paid for in a more population-based way, that's where it's happening most.
The model that we were looking at here at Missouri, I mean, it's a great idea, but there wasn't enough money to hire enough social workers to cover. It's one person per one FTE per, I forget how many patients. And do you think that they might reevaluate that and try to get more people? Because the way it would, for this pilot program, it would only be able to cover 1 or 2 clinics.
Well, there was a very subtle but powerful phrase you used, not enough money. 2.7 or 8, wherever we are today, $1 trillion a year, I would argue is enough money. The problem is the way it's allocated now. Okay? I don't think our problem in the U.S. isn't that we aren't spending enough on health care, it's where we're spending it. So we see studies around things like overutilization. What we need to do are to create systems. It's not to wait for a federal grant or a state grant or a special allocation for a demonstration program. What the future really needs us to do is to move into payment methods where we can redistribute that money to where it's needed. So again, I'm going to use the VA example because I think it's creates a very teachable moment for us. They looked at it narrowly and they said it's $9,000 more to add these salaries for the social workers and so on, when only after they studied it that they realized that in aggregate it was much less than they had been spending before. It was just redistributed. It was redistributed away from the hospital toward the home-based care team. Now, I ran 2 hospitals, 2 health systems. This is a tricky jump to make.
Yes, it is.
If you wake up one morning and the little cough in your catching your throat. If you wake up in the morning and you're staying afloat that day depends on keeping your beds and your ORs humming away. But you know that tomorrow the goal is to be using fewer beds and ORs because you've kept people fundamentally healthier. Then the question becomes, how do you get from point A to point B? And some very bright colleagues are working this problem now. The leader here at Mizzou, Dr. Williamson, who's the Vice Chancellor for Health Affairs here, is actually visiting Virginia Mason next week. One of the systems nationally that seems to be making this transition very effectively.
Caress. Right over there. Yeah.
Hi, I'm Michelle Siebert, and I'm a health educator in Memorial Hospital in Belleville, Illinois. And I have a question. I see one key way to get healthcare, basic healthcare screenings to populations that wouldn't be available to ordinarily would be at food shelter or food pantries. So have you seen any model that has been successful?
A model of helping promote health literacy in different settings?
At the population that comes to food shelters, many do not have good access to health care, but by providing screenings there, health screenings, whether it's cholesterol, blood pressure, health information, have you seen any successful program like that?
I haven't seen programs exactly like that, but there's a program that started in Boston and it's now available nationally, and it's being picked up by college students around the nation. There may be, I get the sense there may be some college students here, maybe some of you have been involved in it, and it's a program called Health Needs. And they train volunteers, generally college students, to be in settings. Now, most of the settings they use are clinics, but they're starting to experience with going to other settings. And what they've trained them to do is actually do health status questionnaires, but they have the ability also to navigate people to resources. So if if they encounter a patient in the clinic who has problems getting their food needs met, they know how to connect them to food banks. You know, if the issue is shelter for a homeless person, they're trained to do that because they conclude correctly that if they meet social needs, they promote health. So they tie social needs among disadvantaged population to health needs. So that program, the program you describe, I think are examples of the kinds of partnerships we just haven't been doing in the past that we can do now to attack this problem. And I think it's very interesting that students, college students, medical students, every medical school in the U.S. has some form of student-run clinic or program for needy patients. I saw somebody's here from Casa de Salud in St. Louis, standing proudly at the back of the room, waiting for me to plug the program. I visited, I guess it was yesterday morning. Yes. I travel a lot. I can't. Where are we today? Wonderful program for Spanish-speaking people, many of whom are disadvantaged in the St. Louis area. And it's a connector program. It isn't picking up their lifelong care, but it's getting them into the system and working and starting to get their health care needs. And I thought it was a wonderful example. The other feature of the program that I thought was very striking was how prominent the mental health needs and social needs of the people are and how they tie the health needs together with that. Was that a pretty good plug that was unplanned?
It was excellent because I was sitting here restructuring my presentation to touch on those points and now I don't have to.
Oh, okay.
Okay, we're going to go back here and then over here. So.
Good morning. I'm Tuck Van Dyne, and I'm Chief for Women's Health in Missouri's Department of Health and Senior Services. And my question is, when you look at the current shortage of physicians and the anticipated future shortage, which is going to be much greater, what are med schools doing to either open up seats in med schools or to accommodate that shortage?
Well, I get national clippings every day, and I've been getting clippings from Missouri talking about, among other things, an effort connecting the University of Missouri and hospitals in Springfield that would expand medical school capacity. And that's a reflection of what we see across the country. We're actually on track to have increased the number of U.S. medical students 30% over the last, it's now 6 years. And that's great. But the problem is The entry to the profession, practice of medicine isn't getting an MD, it's finishing a residency. And our nation, in its wisdom, has capped the amount of support it gives to residency funding, and that is a very dangerous situation for us. We are at grave risk of having done the right thing in terms of building medical school capacity. Nursing schools have built their capacity, but strangling the health system by not appropriately expanding GME, residency funding.
My name is Alejandra Budinho, and I work for the university in something that is called the Family Nutrition Education Program. And what I want to tell you about food pantries is that these programs are federally funded and exist in every state. And maybe it's about time we start looking into partnerships that are not necessarily between medical schools and another medical schools. Maybe doing partnerships with community centers. The Family Nutrition Education Program have about 300 people that work around the state, and they work in food pantries. And they do connecting services. So if you're coming there for nutrition assistance, you can go out home with a lot of other information with you. So that would be one way in which maybe these people will be targeted. Not necessarily a home medical exam, but at least a place to go and get more resources. And so it will be important to try to look not only at community-based organizations, which we have some presence, but how we can make partnerships inside the same universities and the extension, part of every university that is present in every county. And it has a very strong presence.
And I want to underscore your point. It isn't necessary that everybody be in every partnership, that medical schools be involved. But what we need to look for, I think what we need to be critical about is where have the gaps been? And I was as guilty of this as anybody when I was in the leadership of medical schools. We didn't relate to our federally qualified community health centers. They're a key part of the population health care around us, and we weren't connected to them at all. And I've been very interested to see now a lot of the medical schools and teaching hospitals realizing that building that relationship could yield great value for population health.
I'm Barb Jones, and I'm the Missouri coordinator for the National Network of Libraries of Medicine. I was very interested in your comment about teams, building teams and teamwork, and I would like to invite, I think, everybody in this room to look at libraries and librarians as not the place you went to study for your exam, but as a source of flowing information that reaches everybody in the community, whether it be in the hospital or through the public libraries in the community. There's lots of work going on to help with information concerning health care, to give people more education to understand what to do to take care of their health.
Whatever mental image you have of librarians, I think you should replace it with an image of the team informatician.
There you go.
The person who accesses information. And part of the reason I believe this is so critical isn't just on the provider side, but now our patients have access to terabytes of medical information, most of which is not helpful to them. And that's another role the informatician can help play with. But this is one of the benefits. This is why this is the time, because the capacity of technical resources is so great. So in the new schools, one of the new schools, I don't know if any of you have been there, in Central Florida, you go to the library and you don't see books stacked on shelves or journals. You just see their logo, which is any information, anytime, anywhere, any device. And they have one room with books, but to be in that room, the book cannot be available digitally. And when it becomes available, they get rid of it. You know, and that's the future.
Hi, my name is Mehan. I'm studying public health at the University of Missouri. I am from Afghanistan, so a country in Asia, if you haven't heard of Afghanistan. So you talk a lot, and I decided to leave the United States when I saw a movie, Sick Around America, when I watched it the day before yesterday. It was so disappointing. there are many aspects to be improved. So you, as mentioned, the government is focusing on the economic aspect of the health. So I know how much the Americans love the socialism, and I am not going to talk about that, but I just want to mention just one aspect, and since most of you are physicians, I would like to know how much you are ready. I think a part of the problem is the higher income of the physicians. That is what I think, comparing to other countries where physicians or medical services cost very cheaply. So how the physicians are ready to have less salary to demolish this health disparity?
So you're at the University of Missouri, so Dean Churchill is ready to... I have an opportunity to speak to annual meetings of various physician societies, and this issue often comes up. And I'll tell you, the good news is that most physicians understand that part of our problem right now in America is the way we have, not all physicians have high incomes, the way we've under-reimbursed primary care. That by keeping primary care compensation at such low levels comparatively, even when you do comparisons with European nations and others, we've fragmented our system and undermined our system. So physicians agree that primary care salaries, which are down here, do need to come up, and they're very committed to that. The problem is getting agreement about what happens to the ones up here. You know, most of them say, absolutely, this should happen, and while you're at it, this should happen. But the reality is we migrate away, and we have to. We will not be able to manage our national debt unless we migrate away from fee-for-service. There will be compression on physician salaries. It's inevitable. The thoughtful doctors know it, and but again, I think there's more than enough money in the system in the U.S. to manage this. You know, as for your belief that Americans love socialism, stick around over the next 6 months and listen to the news.
Dr. K.
Yeah. My name is Damasin Kurukula Surya. I'm an assistant professor in the School of Medicine, and I have been very privileged to have two unique opportunities. One thing is to be associated with the School of Medicine, which has a very diverse and very great program. It's who is a vanguard in promoting health equity. And then also, as you mentioned, to work under Dr. Thomas Eads, who is the chief of the National HBPC in the VA system, who was from here, actually, from the Truman VA, and then part of this medical school. So having been a former medical director of that program, and also one founding member of the medical foster home program for the VA, I see the great opportunity for partnership, at least with the auspices of the AAMC, with the VA system, with the academic medical community, from a very early stage, like my medical students who rotated with the home-based primary care program, to foster community-based and community development in academic medicine, taking it to the periphery. I'd like to hear your comments on that.
In 1975, my first clinical rotation was on the internal medicine service at the Denver VA. And the first morning I walked in to a ward. It was a room almost the size of this, probably 40 beds in it, filled with patients. And it was not a system that was characterized by quality, by patient friendliness, by attention to outcomes. You go into some VAs now today in the U.S. and they are the best healthcare you can see anywhere. And when you look at the VA indices on outcomes, quality, performance, not every VA, Some are still struggling a bit, but on the whole, it's the best system of its size in the country and one of the best in the world. The reason I say that is for two things. For people who say we can't do that in America, we can't fix health care, we fixed a huge piece of health care in the VA. And the second reason I say it, and don't think this is political, this is just an observation of fact, is it required government involvement. So anybody who believes that the free market, left to its own devices, will automatically fix health care, I don't think that happens. And without the ability of the government to shape, fund, rework, require certain things, the VA wouldn't have gotten there. That's just a statement of fact. You can hate government all you want, but in a society, a civilized society, some things can't be done by the private sector alone. Right. My campaign website is... That's right. How are we doing time-wise?
We have about 7 more minutes. Is that okay?
One question, then I had one thing I wanted to say.
Okay.
I don't really have a question, I guess, as much. I'm Samantha Marquardt. I'm with the Institute for Family Medicine. And I think I just was going to speak on your food pantry / Casa de Salud. I think what I hear when I come to things like this, and I love to come to things like this, is that we all have these really great, innovative ideas, and none of us know about each other. Or we hear about a few folks, and then there's not enough money, and we lose those folks, and we get new organizations. And I think one of our biggest barriers a lot of times to really helping the people that we want to help is that we don't have a way to communicate well with each other and keep each other up to date on what we're doing and who we're helping. And we spend a lot of time maybe helping the same people, and there's people that are falling through cracks. And so I think one thing that really needs to happen in healthcare at a community level and at a large scale level is that we all come to the table more regularly in a more diverse setting. You know, like this is a great setting because we've got academic institutions and small nonprofits and things. But I think that doesn't happen enough, and we spend a lot of time exhausting ourselves looking for the information before we can ever actually help our patients. And that's why I think those network programs are amazing, because they know who's where and we don't when we're seeing the patient. So I think that's a big barrier.
I agree. The thing I want to say, because this is a very hot political time in our nation. We're deeply divided as a nation. I work in Washington. I travel the country. I talk about health care, which some people would say is the most politicized issue we have in the nation. And the reaction I often get back is shame on you, from some of my colleagues too, a shame on you, doctor, you're weighing in on political issues. And I want to make a very clear statement here. Everybody here, it doesn't have the same degree, but you're here because you have made a commitment to work in healthcare, okay? Regardless of your politics, okay? You might be a D, an R, a Tea Party, a Druid, you know. I don't care what your political party is. We've come to work in healthcare. That means we've accepted the obligation to adhere to clinical ethics. And my area of teaching and study, in part, was clinical ethics, which I loved because of its beautiful simplicity. There are only 4 principles you follow. The first one is beneficence, which means do good to the patient, which I bet every one of you wakes up in the morning intending to do, and I think we're pretty square with that principle in this country. The second one is, above all, do no harm. And I don't think we intend to harm people, but I can't look at data like the number of uninsured, the infant mortality rate, without saying there's tremendous harm occurring. I can't walk through an ICU and see people suffering at the end of life who should be in palliative care, receiving the comfort of palliative care, and not believe we're missing the mark on doing no harm. The third principle is autonomy, which means we're supposed to respect the autonomy of patients, but we seem to have gotten caught up in a time when it's all about my autonomy as a provider and the autonomy of my income. So I think we're even farther off the mark there. The fourth principle you will find in virtually every textbook of clinical ethics is social justice. It's not a political statement. It says if you commit to health care, you can't ignore that the health of the population and the health of the individual are inseparable. And you have an obligation to think about the justice of the system. What I have described today is a system filled with injustice. I don't experience it, but every day we all see people who do experience it. My area is mental health. There's a man on a corner beside near my office I pass by every day who clearly has chronic schizophrenia, the area of my research study. He's out of our system. He's ill, actively hallucinating all the time. That's injustice. And that's where I'm coming from. I won't tell you what my political affiliation is because it doesn't matter. It's the ethical affiliation that matters. Thank you.
I think we're going to end there.